We'll talk about carotid stenting. I want you guys to take home certain take-home messages as to some of the principles. How do we do them? Maybe if I have time, I'll talk about some trials and some surgical stuff. So just FYI, for anybody who's interested in interventional cardiology, you got to do 25 supervised carotid stents to go out in the country and do it yourself. 13 of them has to be as primary, 12 of them has to be as a secondary operator. That's a must requirement today. Every carotid stent requires a patient to be on DAPT the minute they lay on the table, and every carotid stent requires a neurology evaluation pre-stent. Post, yes, encouraged, but not mandated. Our site has been doing carotid stents for a long time, more than 10 or 15 years. I myself got involved about 16, so almost 8 or 9 years ago. There are 3 departments in our hospital which do them: vascular surgery, interventional neuroradiology, and us in the cath lab. As of today, we are responsible for about 70% of all the carotid stents done in this hospital. Ours is the largest carotid stent program in the state of Texas. Probably the largest, if I'm not wrong, in the country as we speak. So we are a very, very busy carotid stent operator. But there's an MSQM, CPI, there are several committees which work around it. So that being said and done, this is a good institution to learn and treat carotid disease, guys. Our stroke guys are involved and everybody else is involved. So stroke is the number 3 cause of mortality. About 20% of all the strokes happen from carotid atherosclerosis. As we speak right now, endarterectomy is done way more frequently than carotid stenting because the vast majority of the country does not have carotid stent as an option. As you guys become interventional cardiologists, as in the last 5 years, all our IC guys, as they've gone into practice, they've started their own carotid stent program. So that's what we hope. We'll keep on doing that. There is rapid expansion of indications for carotid stents in whom we can do and who can be eligible. So, this is true for every carotid anatomy, everything. So most of the carotid blockages are right at the bulb area or within the first 2 or 20 millimeters of the carotid artery bifurcation. Carotid artery itself does not have any branches in the neck. Internal carotid artery. The external carotid artery does have several branches forming the neck. The first one which comes out is the superior thyroid artery. That's a very important artery. That's important for intervention. Then you got 3 other branches of the external carotid artery, and we'll get to that in a second. So, we get patients referred for carotid artery stenosis, and there's always this debate: is this patient symptomatic? Is it asymptomatic? So, just to clarify a few things, dementia is not symptomatic carotid disease. Neither is headache, nor is dizziness, nor is loss of memory, bilateral weakness, bilateral sensory deficit. The commonest symptom of carotid artery stenosis is asymptomatic. Vast majority, about 80% of the patients comes to our cath lab are asymptomatic. But then you can obviously have unilateral hemiparesis, unilateral hemianesthesia, hemianesis freedots, or monocular blindness, unilateral facial weakness, and dysphagia. This is very important to know because you guys need to understand as you get into this field what are symptomatic versus asymptomatic carotid artery disease. But remember, the vast majority of the folks with carotid artery stenosis are asymptomatic, even if it's 80-90% time. So there are various ways we can image a carotid artery. One is obviously the ultrasound, and you can see the flow velocity acceleration and the mosaic flow fluid. You can get a CT and you can get an MRI. CT tends to be difficult when somebody has a lot of calcium. MRI tends to overestimate, and angiography tends to be single plane or biplane. does not have a very good view of the eccentric decline. So those are some of the limitations. Vascular ultrasound is a good way of starting screening for those, especially if somebody is weak or has multiple risk factors. The limitation is just lack of fluid utilization. And that's where we are trying to probably do some optison injections to see if we can improve that technology. So these are the branches, or these are the segments of the carotid artery. The common carotid artery, right at the level of C2, C3, vertebra, gets divided. The first portion is called the bulb. Normally, the carotid artery, the carotid artery, has many of the bulb as a bulb. The first branch which comes out of the external carotid artery is the very thyroid branch. Then you got three other branches: maxillary, tympanic, and occipital branches of the external carotid arteries. Those are important only when internal carotid arteries are fluid. Sometimes this can be responsible for truck failure to truck failure. Again, going through the segment, the cervical portion of the internal carotid artery, uterus, then cavernous. There are about 7 different categories. Why do you think this is called uterus of uterus? Any thoughts? What is it? Yeah, that's what it's called. Because it towers is right next to the petroglyph. What about the cavernous? The big sinus called the cavernous sinus. Runs around the cavernous sinus. In my, about 7 years ago, we actually had a wiring operation to the cavernous segment to the cavernous sinus. That guy had severe pain behind his left eye. The aortic arch types, again, very important to understand. So what are the three movements of aortic arch as we get old? What happens inside the chest? How does it shift? There are three movements. It moves more posterior, superior, and it moves more lateral. And that's why an arch of a 20-year-old guy, by the time he's 80 years old, is very different. There's a push up. So that kind of makes everything harder. So if I type 1, 2, and 3 arch, basically the way you kind of roughly define it, that if your right nominal artery origin is above the superior margin of the arch, then it is considered type 1. Type 2, origin of the right nominal artery is below the superior margin of the arch. And in type 3, the origin of the right nominal artery is below the margin of the arch. Basically, the reason we classify them is because it kind of gives us the complexity. Now imagine you want to do a right carotid stent. You've got a catheter which goes up here and goes up like that. Now imagine you've got to do a left carotid stent. The catheter go up here, come down. That's why knowing the type of arch is very important. Bovine arch happens in about 15-20% of the folks. And again, this is where the left common carotid artery originates from the right innominates from. What is a true bovine arch? Okay. Yeah. This is actually a pseudonym. The true is only one. We have a couple of rare anomalies. Who wants to volunteer? What do you guys see here? This is easy. Yeah. You guys see that? In the right dominant, left carotid, left vertebral, and then left ventricle. Where does normally the left vertebral come from? Yeah, this is actually very about 7 to 10% of patients have this isolated left vertebral origin. Not that's good. And then what is the anomaly here? Yeah, that's it. Here it is, the last bit of. So this is the cerebral arteries, circle of Willis, probably the most important organ of the configuration in the human body, circle of Willis. And that's why we have all those patients in occluded carotids and occluded vertebrals and are completely asymptomatic. And the reason is because circle of Willis. Circle of Willis is literally a circle of blood artery circulation which sits at the base of the human brain. So there you go. This is a good representation. And what you have is, this is the front, this is the intracarotid artery on the right, intracarotid artery on the left. Then this anterior cerebral artery. And there is an anterior communicating artery which completes the circle, and the back is posterior communicating artery which goes to the vertebral basilar system. Imagine any one of these getting activated with persistent blood flow to the brain. We see this again and again and again. And that's why we strongly recommend not to intervene on something which is completely blocked. Do not send there for surgery. Do not send there for stent. Leave those guys alone. Like this example, anybody this person probably is totally occluded, that's the carotid artery. Especially when you get the right carotid artery, everything. This is very common. We should really refrain from doing anything to something which is totally occluded. Leave them alone. Focus on the other artery. All right. Any questions so far on the anatomy, or everybody's on the same? Everybody got that concept. I know I'm going through it rather quickly, but anyways, so we've got a lot to cover. So what about pre-stents? Well, there are approvals, and without getting into a lot of details, I'll give you some basic idea. You can do carotid stents on anybody. So what we are already approved for on label is high risk for surgery. You got to know three categories. What is the risk of surgery? What is the symptom status? And how bad is the lesion? I think how bad is more of a surgical conversation, because surgeons sometimes operate when the blockage is 60-70% low. We would not touch it unless it is a hot symptomatic carotid artery. So for us, it is risk of surgery and the symptom status. So anybody who's high risk for surgery, we'll go through the list in a second, then is a good candidate for carotid stents. In terms of symptoms, anybody who is symptomatic is also a good candidate for carotid stents. Patients who are not surgical high risk but symptomatic also good candidate for carotid. Now, anybody's game is asymptomatic patients who are average surgical risk. 60-year-old person on a screening, they found 90% stenosis. What are you going to do? That patient can be sent for surgery or can be sent for stent. Now, the stenting comes with all the aspects. What I mean by that is it should only be done with a high volume expedient stenting, especially those asymptomatic. Now, our surgeon may say that there are no high-risk patients, but that is not true. All the surgical data on the carotid endarterectomy are derived from low-risk surgical patients. So there is not been a single trial of carotid surgery in patients who are high risk for surgery. There is no TAVR kind of a work. So everything is based upon average risk. So based upon that, we have created two categories. What is called clinical high risk and anatomic high risk. So clinical high risk are pretty obvious, logical. Severe angina, severe CAD, congestive heart failure. So all those patients in our advanced heart failure program are basically high risk for carotid surgery. LV of less than 30% death, COPD, and so on and so forth. The anatomical high risk includes, these are very interesting and these are very important to remember. So anybody who has lesions which are very high or very low, where the surgeon cannot get the access to the nerve. Contralateral carotid artery, very important. So somebody who already has one side blocked, he should not be going to surgery for the other side in case of the with stenosis after previous ipsilateral CEA, so when somebody's already gone through surgery and comes back with the stenosis. What are the rates of stenosis after endarterectomy? Any guess? About 7 to 10%. Previous head and neck radiation, obviously because of the scars and the addition there. Ipsilateral radical neck dissection, such as after thyroid cancer treatment. Obese, short neck, FMD, spinal immobility, contralateral laryngeal palsy because there's a high risk of laryngeal palsy, damage in surgery, tracheostoma, and tendon lesions, multiple blockages. So these are the anatomical high risk for carotid surgery. Well, we also learned that there are certain patients who are high risk for carotid stents where we don't rush into those. So anybody who has had a major stroke within the last 4 weeks, try not to touch them. We usually quieten those flat down with a combination of that, along with some statins. And then after 2 to 4 weeks, I'll bring them back to the cath lab, which will do a carotid stent. Obviously, allergic reactions, kidney problems. Older age, you don't really know what is the correct therapy, or a surgery, a stent, or just maybe a medical therapy, or just maybe a symptomatic. But spring sign, I want to spend a little bit of time on spring sign. Who can tell me here what is a spring sign? Any takers? Have you guys ever heard of that? Rob, have you read any string signs?
I have.
Oh, tell us
So
what
it's
it is.
like it's a chronic occlusion with it's a chronic polar occlusion with basically surrounding.
Yeah, excellent. So remember, have you guys heard of bridge collaterals in the economy? Bridge collaterals? Bridge collaterals are nothing but vasovasorum. Vasovasorum are the small pole arteries which supply the smooth muscle cells in the media of the human coronary artery. Every cell needs its own oxygenation. It needs its own artery. That's what vasovasorums do. They supply the muscles in the blood vessel wall. Then, when the lumen gets enclosed or completely occluded, the blood starts trickling down the vasovasorum. And that almost runs parallel with the anatomy of the artery. Sometimes it's almost hard to differentiate with the bridge collateral and with the occlusion. That is vasovasorum. The same process that happens to any of the arteries, including the carotid. In the carotid, we call it a spring sign. So when we inject or when we do a Doppler, you can see a trickle of blood flow with the velocity that's absolutely damped. It's basically just a little trickle of blood flow. And the reason that is happening is the blood is not flowing to the lumen, it's flowing to a tiny vasovasorum. Don't touch it. Just surgery, nor stenting ought to be done for spring sign occlusion. These are occluded carotid artery. We should be left away. So there are certain high risk anatomy. What is this? This here, basically a giant clot, thrombus. Try and stay away from them. Put them on aspirin, Plavix, and if you can do it, and we have done few of those, but I think these are high risk. This is high risk because there's people of age, about the reason not because of its time. The for us sometimes it's hard to play total and we are so cautious. This is pretty obvious, right? What is this? What is that, guys? No, what is all this? I have wrong. Awesome. It's about awesome. There you go, string sign. So subdural occlusions, we talked about that, so I'm going to move on from there. But this is what it will show. It will show as a tight stenosis. And there is a little bit of a blood flow. And you say, wow, is it 99.99% block, or is it actually string sign? And the telltale sign is, how do you know if it's a functional, and this applies to foreign skin. How do you differentiate a functional occlusion and a tight stenosis? 99%. Blood flow does not lose its velocity after the stenosis. Then it is post-luminal stenosis. If it loses velocity, it off. That usually is the total occlusion. How the blood goes beyond the lesion is very telling. And so a lot of times I'll always ask you guys to stay on the pellet, because I want to see how the blood flows rather than just doing it quickly. All right. I've got 15 minutes. Do you guys want to talk about devices or trials? Any thoughts? Trials? Sure. You can read trials. Okay, let me go back. Because you guys are all going to scrub sooner or later, and you can, as I said, yeah, you can read a crawl. So, okay. So I'm going to talk about the more important stuff, so to speak, and try to feel free to stop me or if any questions that coming from there. So in our cath lab, we do them all under conscious sedation. Patients are awake. Downstairs in the vascular ward, they are all under general anesthesia. The interventional radiology is done under, what do you call it? Oh, limited conscious sedation. Um, all the stents are self-expanding nitinol stents, and we use embolic protection device in probably 100% of the cases. I think I just did my 500 carotid stent. Looking at my data, I've done only 2 without embolic protection device. So everybody gets a protection device. Now, when you guys go into your field and realize that there is some debate about carotid stent versus surgery, one of the biggest criticisms is embolic protection device was not mandated in all those trials. This is very unfortunate. Every little tiny plaque you're going to break loose is going to cause you damage. And we try to aim for fluid devices more for early ambulation. And I'll get to that in a second. So we have varieties of catheters, what are called styptic catheters. These are very hydrophilic. Varieties are shaped like our orange catheters. And this allows us to selectively cannulate into this variety. The H ones are simple, but then we have what I call JD1, JD2, SIMS1, SIMS2. And they are really, really very neat catheters to actually prolapse them into the aorta and pick them up. We use 035, 038 guide wires to get those sheets up into the carotid. And then once we have got the sheets, we actually take 014 wires. So this is the basic principle of a embolic protection device for our stent. What we have is a filter-like device. It is called exact. That's actually the name of the filter, or ambush shield. And we bring that over it over 4 wires, the cut corner wire, so the filter on top. While we have the filter on top, we actually start working on the carotid artery, dilating and stenting. And also distal occlusion balloons and proximal occlusion balloons. And I'm going to show you that in a second. But the commonest filter is our the umbrella filter, ambush shield. So this is what it looks like. This is an actual photograph of that. We've got the filter sitting up on top with 140 microns, and the pore size are 140 microns. The stent is a nitinol stent. It is a tapered stent. It comes in sizes like 9 by 7 by 40. So it's not like a corner stent which is 3 by 20. This is like 9 by 7 by 40 or 8 by 6 by 30. So there's a tapered stent because a common carotid is much bigger than a carotid. This is what we get. Time and again, we'll get a lot of embolic material, and that's what the filters do distally. This is a proximal occlusion device. Proximal occlusion device is MoMA. This is a very unique device, and this allows me to go after highly thrombotic carotid arteries, making the shortest carotid arteries. This uses the principle of carotid end artery. Have you guys, anybody seen here end artery? Okay, great. Since you raise your hand, you're going to tell me how to do it. So what the surgeon opens up, so first there's a nodule inclusion, opens that up. It's a transverse inclusion at the bow, right? And what does it do before you mix it?
Well, I mean, I think what this is getting at is they have basically a bypass.
Okay.
Plant both sides of the bypass.
Yeah. So blood in the human body doesn't know which direction to go. There is no GPS in the blood cell. Blood goes wherever the pressure is low. Blood can go fixatory, left and right, doesn't matter. It follows pressure. So what this endarterectomy is done is you open up the neck, you put a clamp into the external carotid artery, clamp the common carotid artery. You clamp the common carotid artery, nothing is going to force the blood up to the internal, correct? Does that make sense? But then instead of the external carotid artery, it is going to reverse and go up into the carotid artery. You clamp the external carotid artery. So now you have a static column, no flow column. And then you open that up with the transverse incision. Just good. These are all the atherosclerosis. When you say back up, you release the flux. And that's the static column, so nothing embolizes up to the top of the blade. That's how endocrine is. This kind of uses the same principle. So what I do is they take a balloon. First, this is a catheter, which is a balloon outside the catheter. That is the common carotid artery. The Y configuration is the carotid artery, the carotid artery, and allows the static column here, the carotid artery. If somebody has large clot in there, I don't have to worry about embolizing one of those clots and mucus. So this is a proximal occlusion. And we sometimes will occlude the arteries for 6, 8, 10, 15 minutes. Patients will have no cervical ischemia. This is remarkable, again, because of circular Willis, because there's enough flow that the patient can tolerate occlusion really well. Sometimes I would combine both of this. I would put in a proximal occlusion and a distal filter wire to kind of capture any clots. PCDs, again, we use, and you guys may have seen the Carotid. We did a lot of work on this about 3-4 years ago on doing quadrilateral things to capture anything. But in the TCD data, we actually compared the filter data and the goal reversal data. You can see there are a lot of hits. These are all the hits. Let's say grow and a lot of people. This was approximately for reversal, almost a year. That's why whenever somebody has a very thrombotic lesion, we usually almost always use the proximal occlusions. Again, I think a lot of times on IVUS we can predict which patients are going to have a high thrombotic risk depending on their fibroathyroma as well as necrotic cores, and more than necrotic cores. So more than 3 correlates with embolic event strokes, and we notice that. Okay. So complications, obviously PI stroke, a minor stroke happens in about 4%, major stroke happens in about 1% of all the trials. So our center's experience is even better than that. Our risk is probably 3% and then 0.5%. So the commonest is vasovagal reaction, really bad on the left. There's a patient who has a really hard time getting up and moving around after a carotid stent. Not because there's any problem, because of vasovagal. So vasovagal happens in almost vast majority of carotid stent and carotid surgery, especially carotid stent, because we are applying a lot of pressure from inside out. And it presses on this nerve, which is a branch of the glossopharyngeal nerve, the carotid sinus nerve. Carotid sinus nerve is a very important nerve. That is how we regulate our heart rate and blood pressure. Have you guys thought about why in the world we do carotid sinus massage and it keeps an SCP? That's what it does. You're actually tickling the carotid sinus nerve. That's how it does that. And so the same process, now really applying so much pressure on it, it makes your blood pressure and heart rate really drop. You have interfaces that are after it. This is very common, and we let the patient admit it faster. It allows the blood pressure to improve. I would say 95% of the patients go home the next day, about 5% the next day. The older they are, the more likely. All right, wrist stenosis, believe it or not, hardly ever wrist stenosis, and that's one of the beauty of carotid stent. You take care of day one, that patient is pretty much guaranteed to go through the rest of his life without any problems. Unlike the coronary field, we have never had to deal with these stenotic issues. And that's really, really amazing. It's almost less than carotid surgery. There's one thing the surgeons do to reduce wrist stenosis. What is that? When you do carotid endarterectomy, there's one extra thing they start doing. Have you guys seen endarterectomy op reports where they would say, we did an endarterectomy patch angioplasty? What is a patch angioplasty? Radical patch. They basically sew an extra patch as they're closing the carotid artery. Basically increases the lumen, so this stenosis begins. That's important. And we actually have this technology where the wrist stenosis rates are even less than carotid endarterectomy. And the reason is because it's a non-muscular artery. Any other arteries which are non-muscular? Excellent. That's why Lehman does not fail, except for what part of Lehman is very muscular. Awesome. The more cats we do, the more we will cause this. Lima ostomy is the only part of the lima with muscles. The rest of the lima has no muscle. That's why it does not almost do. What else? In the legs, all the legs are resistant so much, so they have to be very muscular, right? You've got restenosis comes from sweetness cells immediately. VX. VX almost never restenosis. That's more again because of very, very little bit of muscular tissue. Oh, there you go. This is endarterectomy. So, that's and endarterectomy obviously have complications, so we're going to skip through all of those. I don't know why it's showing up like this. Oh boy, clinical trials. I'm going to talk about, without showing you guys slides, 2 clinical trials. There are really great clinical trials, and they do speak forever and ever and ever. First one I want to tell you guys is CREST trial. CREST trial was very important because we compared multi-center trials, we were part of that. Multi-center trials where we had about 2,400 patient enrollment. Half of those patients underwent carotid surgery, and half of those patients underwent carotid stenting. These are all comers, symptomatic or very asymptomatic. The primary endpoint was death, stroke, and MI at 30 days, plus ipsilateral stent or stroke at 4 years. And the trial showed there was no statistical difference between the two arms. In the surgical arm, we saw a little bit more MI. In the stent arm, we saw a little bit more of a non-major stroke or minor stroke. That was CREST. The one we are doing today is called CREST 2. Have you guys heard of CREST 2? So CREST 2 is run by David Chu, and there's a very interesting trial. So this basically looks at all asymptomatic patients, average risk, all asymptomatic patients, but found with 80% blockage. We're going to have it's a double randomization. One arm is going to get randomized of surgery versus medical care. That's going to lie with sadness. Other arm is going to be stenting versus medical care. This is in progress. We are working on it. Maybe another 5 years, we're going to have more data. The other trials, I mean, all the trials have been non-inclusive surgery, but there is always this debate. Now, there's also a general accepted idea that younger patients do really well with stenting, older patients probably ought to do better with surgery. But again, this is such an, center-based data. Our center, I think that's the only time I'm allowed. So, any questions? Anything you guys want to ask before you all run to the cath lab?
How do you document the high risk? Request document that?
Yeah, so that's an excellent question. So every patient requires a neurology consult. Unlike what we would like to think, neurology consultation is not to assign the risk, because they would not know about class 4 angina. Neurology consultation is not to approve a stent or surgery or medical therapy. Neurology consultation is only done to assess the baseline status of the patient's neurological condition. Period. We don't want neurologists to say the patient is even a candidate. We always write that, but it is not required of them. We are only doing that because we want a baseline independent neurological assessment. Now, so the risk assessment and the options of treatment assessment to the patient or this patient is usually done by the operator. If it's a stent operator or surgeon. That's going to fall up to us. Talk to our patients, let them give them the options. And obviously tell them that we do not require, unlike a TAVR, we do not require independent surgical evaluation of complications. For us, the neurological assessment is really more important. And high risk was very important about 5-6 years ago, but now carotid stent has become so successful that less and less people worry about it. We have to agree with that. Yeah. Yeah, there has been. So we actually have looked into that. Again, this is all non-inhuman. There are varieties of newer types of carotid stents also available. We have what I call micro-pore carotid stents. We have stents which will allow us to have preservation of the external carotid glands and so on and so forth. We also look at bioabsorbable there. And again, it's all in human, not in human studies, big labs. We don't really have enough data. The reason for bioabsorbable stent is twofold. One is, why do we do it in coronary? One is we want a metal-free artery, and B, we want vasomotion restored. Well, both of those things are probably not that important in the carotid artery. The restenosis, as I showed you, is not a major problem to begin with. And vasomotion is important. However, once you put in a bioabsorbable, it takes you 18, 20 months for it to resolve. And you already have kind of reset your vasomotion. So that is more an experimental idea at this point rather than real. Because again, the challenges of coronary fuel of restenosis non-existent in carotid. Fix it, you almost never see those carotid. All right, guys. Thank you all. And next time we'll do trials.
Today, at the Imaging Journal Club, I'm presenting an article about the relationship of coronary calcium seen on standard chest CT scans
Are you go
in
gambling
relation to
everybody?
mortality. So, just a little background. We all know who rotated on CT nuclear, we do a lot of coronary calcium scoring, and that's previously been associated with mortality, depending on your score. Now, CT calcium scoring is done with 3 millimeter slices. It's ECG gated versus a standard chest CT scan, which is 6 millimeter slices and not ECG gated. And what these authors of this paper were thinking is, hey, we do around 600,000 coronary calcium scores a year to help prognosticate people from a cardiovascular standpoint. So there's over 7 million non-coronary chest CT scans done that nobody really comments on calcium. So
7 million.
They reported 7.1 million done annually for other clinical indications. So what they did in this study is they took a group of patients, these what they call community, what did they say? Something like just community per people. So community living individuals. So just regular patients who are referred by their doctor or self-referral for a whole body CT scan. So really no clear indication for the CT scan, but they went for that. They also had a calcium scoring done at...
Yeah, it's very common in Asia. Very common in the heart failure.
This is San Diego. Yeah, so all these, so that's how these people got in the study, and they were enrolled between the years of 2000 to 2003. Then they were followed for mortality for cardiovascular events up until 2009. So for almost 8 years. The way that so there were over 4,500 patients that initially went to this. What they did is, of those over 4,500 patients, there were 103 participants that died. Then they used a nested case control study design and matched those deaths with 3 patients who survived. Is how they created the study cohort. So they ended up with, how many patients? A total of 651 patients, 157 deaths, and 494 controls. They excluded patients who had undergone a coronary angioplasty, stent, or bypass revascularization procedure. That was really their only exclusion criteria. So, like I said, so all these people had the chest CT and a coronary calcium score. The calcium score was scored at the time of the exam, so whenever they were enrolled in the study, but they didn't. They retrospectively looked at calcium on the chest CT scans in 2012, and correct, yeah. So they had a dedicated calcium score and a whole body chest CT scan or whole body CT scan. But the readers of the chest CT scans, in retrospect, were blinded to the patient, blinded to the participants' clinical data as well as their results of the calcium score. This is just a section talking about the different scanning techniques. The baseline millisievert scan for the coronary calcium score was 1 to 1.3. For the whole body, it was a low dose CT scan for the 6 millimeter because it was 1.5 millisieverts.
5 millimeters,
Yeah.
whole body.
Well, yeah. So they say, so radiation exposure to this type of scan is presented in lung cancer screening literature for low, oh, so maybe they don't know. So they said low dose CT scan. Imatron C150 scanner. Okay, so
Not fast. Global.
short. And they got their mortality data by looking at the Social Security Death Index. They looked at patients, so patients' height and weight were actually measured. Otherwise, age and sex was obtained by self-report, and they had a questionnaire of their other health, or their other comorbidities, which is how they acquired their data. So, Table 1 just shows you the baseline characteristics of the two groups, and just to point out a few differences, more diabetics were in the, and so cases are actually the people that died. So they were more likely to be diabetic. They were more likely to be smokers, I guess current smokers, and more likely to have a positive family history. So they looked based off of let's see, what did they say exactly? So I'm not. So 103 patients died using an nested case control each day, matched on sex and age within 1 year, with 3 surviving controls. So they had to be within a year of the same age. No. Okay, so this just shows the correlation between the two scanning types. So on the y-axis, it's a 6 millimeter chest calcium score, and then the 3 millimeter ECG gated. And their correlation was 0.93%. So they, seemed to follow along pretty well. Now, having said that, obviously, the 3 millimeter slices were more sensitive and picked up more people, or picked up more calcium. So, yes, sir. So they did it. They used it the same way, the Gadsden scoring.
Yeah, that's a method. The workstation.
Oh, I don't think they said anything about that. Let me see. Let me just make sure. So, did they say methods for scoring calcium were those described by on both scan types? Yeah, they didn't really elaborate. So the 3 millimeter ones, as you would expect, were a little bit more sensitive. So in evaluating the 6 millimeter chest CT scans, 34% had a score of 0, whereas only 24% actually had a score of 0 on the 3 millimeter scan. So 10% were classified as 0 on the 6 millimeter that actually weren't 0. 10% of total. So of the, I guess, of the patients, when they looked at their 6 millimeter chest CT scan, 34% had the calcium score of 0. But when they compared that to their 3 millimeter scan, only 24% had the score of 0. So there's a 10% difference.
1/3.
1/3 of the total population of patients screened had a score of 0 on the 6 millimeter.
Then another 1/3.
Yeah. Correct.
Okay, those 10% means what of the score?
No, it doesn't say. This is the only paragraph where it said anything about that. And it doesn't say anything. Okay, so to the results. So obviously, we already addressed the correlation between that. Although it's not as good as picking up calcium, it still does pick up calcium, and it correlated pretty well, meaning the higher the score on the 6 millimeter correlated with a higher score on the 3 millimeter scan. The median scores were quite different, however, so 6 millimeter versus 3 millimeter was 22 versus 104. And they actually found that on average the 3 millimeter slices were 323% higher than the 6 millimeter counterpart. So like an order of 3.23. Yeah.
Any patient that false positive?
It is. I think it would. Yeah. No. These are just examples of the differences, but we don't need to look at that. So, I mean, the main issue, so this is just looking at the outcome. So on the 6 millimeter non-gated chest CT, you know, your risk of death increased as your calcium increased, which we'd all agree is a well-done statement. Similar to the way that it increased on the 3 millimeter slices. So, I mean, that's pretty much it. You know, I think that their main point here is that we use calcium scores to prognosticate patients from a cardiovascular disease standpoint. But I think the purpose of this paper was saying we're missing an untapped resource of CT scans that are being checked for something completely different, but could lead to prognostic data. You know, they said that over 40%, so they said 44% of the patients with known calcium, there's no report in the CT scan of that coronary calcification.